Good morning, everyone. My name is Florence Wong from the University of Toronto. First of all, I would like to thank the organizers for inviting me to discuss with you the topic of ascites and acute kidney injury in cirrhosis. Here are my disclosures. In patients who have cirrhosis, there is usually a long period of compensation or the pre-ascites stage. At that stage, patients usually had subtle sodium retention. However, when a patient decompensates with ascites, there is obvious sodium retention. Initially, the patient is responsive to diuretics. However, as the patient progresses along the natural history of cirrhosis, the sodium retention becomes a lot more avid, and ultimately the ascites is refractory to diuretic therapy. At that stage, the patient may also develop hemodynamic abnormalities, leading to retention of excess free water and hyponatremia, or the patient may develop hemodynamic abnormalities, leading to gradual deterioration of renal function. At some stage, an acute precipitating event may occur, leading to acute deterioration of renal function or the development of acute kidney injury. So this is the patient that we are talking about, a patient with distension of his abdomen related to the presence of ascites. And such a patient with overt ascites has a fairly poor prognosis with 50% mortality estimated at 4 years. This poor prognosis of patients with ascites has always been known, as depicted in this 18th century English cartoon showing a patient with ascites needing 3 hepatologists to take care of him. Now, in order to understand the treatment of ascites, we need to understand the pathophysiology of ascites formation and renal dysfunction in patients with cirrhosis. And I promise you, this is the only pathophysiology slide I have for the whole talk. In patients with cirrhosis, because of distortion of liver architecture, there is obstruction to portal flow, leading to the development of portal hypertension. And this is followed by the development of 2 events. One is the increased translocation of gut bacteria and bacterial products from the gut lumen into the splenic vasculature. And a lot of these bacterial products are actually vasodilators. And the presence of portal hypertension can also increase the shear stress on the splenic vessels, which will result in an increased production of vasodilators. The end result is vasodilatation of the splenic circulation. And so the capacitance of the circulation is increased without actual loss of intravascular volume. This condition is known as a reduction in the effective arterial blood volume. The physiological response is the activation of various vasoconstrictor systems in order to improve the hemodynamics. And it will also stimulate the kidneys to retain more salt and water. Therefore, the circulatory volume of patients with cirrhosis is expanded. The presence of portal hypertension will then preferentially localize the excess fluid into the peritoneal cavity as ascites. Now, on the other hand, in patients who have got increased translocation of gut bacteria and bacterial products, these molecules known as pathogen-associated molecular patterns, together with damage-associated molecular patterns from hepatocyte necrosis, will stimulate the immune system, producing an inflammatory response. The inflammatory cytokines can also cause microthrombi in the renal microcirculation, further compromising the renal circulation, putting such a patient at risk for the development of renal dysfunction. So when a patient presents with ascites, the first thing that we have to do is to decide whether the ascites is related to the presence of cirrhosis or related to peritoneal disease, such as tuberculous infection of the peritoneum. And the first thing you do is to calculate the serum acidic fluid albumin gradient, or the SAG. Remembering that patients with peritoneal disease tend to have increased secretion of albumin and protein into the peritoneal cavity, and therefore the acidic albumin concentration is usually high, making the SAG low. In contrast, patients with cirrhosis or obstruction to portal flow usually have very low acidic fluid albumin concentration, making the SAG higher than 1.1 gram per deciliter. Having decided that the patient has cirrhosis-related ascites, how do you manage such a patient? The first thing you need to do is to work out the sodium balance. And you do this by calculating the patient's sodium intake versus the patient's sodium excretion. We traditionally recommend a 2-gram sodium intake or 88 millimoles of sodium to be taken per day. If the patient's 24-hour urinary sodium excretion is 88 millimoles per day, then the patient is in sodium balance. The ascites will not increase nor decrease. However, for a patient who is excreting no urinary sodium, then the intake of 2 grams or 88 millimoles sodium per day will lead to an accumulation of 14 grams of sodium per week. And when you divide that by the acidic sodium concentration, which is 3 grams per liter, the amount of ascites accumulated per week is 4.6 liters. And so if a patient comes to you and wants 10, 20 liters of ascites removed per week, even if the patient is not excreting any sodium, the patient is definitely taking more than 2 grams of sodium per day. And such a patient will require dietary counseling so that he can reduce his sodium intake. Now, ascites has been known throughout the centuries, and you can see in these cartoons, the early Romans already knew how to treat ascites, and that is by performing a large volume paracentesis while monitoring the patient's pulse carefully throughout the procedure. And let's fast forward to 18th century England. The physicians in England in those days recommended that patients should go into a bath. This is because by soaking a patient in a bath, especially with the water coming up to the level of the neck, could actually induce a natriuresis and diuresis. This is known as head water immersion. The external water can actually exert hydrostatic pressure on the vascular columns of the body, thereby forcing the blood from the lower extremities into the intrathoracic vascular compartment, and therefore lowering the levels of the sodium retaining neurohormonal systems. It's been calculated that the pressure exerted increases by 22.4 millimeters of mercury for every foot depth of water. And the result is a natriuresis and a diuresis, as demonstrated in this nice experiment performed in the 1970s. However, it is not practical to immerse a patient for several hours per day, and it's also difficult to find a big tub to immerse these patients in. And therefore, we treat patients with ascites with a combination of sodium restriction and diuretic therapy. More recently, albumin infusions have been used to treat patients with ascites. And I'm just going to discuss with you a couple of studies. The first study, or the ANSWER study, is from Italy, showing that in patients with uncomplicated ascites who were given 40 grams of albumin twice weekly for 2 weeks, then 40 grams weekly for 18 months, such patients were able to maintain the serum albumin concentration above 4 grams per deciliter, associated with significant improvement in survival. Further sub-analysis of the data shows that in those patients who were able to maintain a serum albumin level of more than 4 grams per deciliter had a significantly better survival compared to those patients who had a serum albumin concentration of less than 4 grams per deciliter. In fact, they showed that even a minor increase in the serum albumin concentration was associated with an improvement in the 18-month survival. However, these results contrast significantly with those of a Spanish study. These investigators were using a lower dose of albumin, 40 grams every 2 weeks, together with the use of midodrine as a vasoconstrictor to maintain the mean arterial pressure. The median dose of midodrine used was 23 grams per day. They followed the patients for slightly over a year, and they were unable to show a significant improvement in survival, nor a reduction in complications of cirrhosis. So what is the difference? The ANSWER study assessed patients at a slightly early stage of their cirrhosis. Their MEL score was slightly lower at 12-13, whereas those patients in the MAC or the Spanish study were sicker with a higher baseline MEL score. In addition, the patients in the ANSWER trial received albumin at a greater dose and for much longer. Then perhaps it is not so much just the use of albumin, but rather how long you give it for and what dose you give these patients. And after the publication of these two studies, there was another Italian study that came from Padua in Italy, which showed that the use of albumin given twice a week, 20 grams, in addition to the standard of care, was able to reduce the risk of hospitalization as well as reducing the risk of mortality. And so the use of albumin as a treatment for ascites is currently still being debated. There is a study being conducted in North America and in Europe called the Cirrhosis study, which will hopefully answer the question as to whether patients with ascites should be treated with frequent albumin infusions or not. Now let's turn to patients who are at a later stage of the ascites. These are the patients with refractory ascites, which could be diuretic resistant or diuretic intolerant. Patients with diuretic resistant ascites are those who are receiving maximum doses of diuretics without significant loss of water weight while adhering to dietary sodium restriction. Patients with diuretic intolerant ascites are the ones who cannot have the diuretic doses increased because of the development of diuretic complications. And so these patients could either be treated with repeat large volume paracentesis together with albumin support, or they could be referred for liver transplant assessment if there is concurrent liver dysfunction, or they could be considered for TIPS placement. Just a couple of slides about large volume paracentesis. He is our ascitic patient with his abdominal fluid And here is his cirrhotic liver with portal hypertension. And the force of the portal pressure will be to push the fluid from the central circulation into the abdominal cavity, while the serum albumin will try to retract the fluid back into the central circulation. And here's a tap that the patient receives intermittently in the form of large volume paracentesis. Removing large volume of ascites will lower the pressure within the abdominal cavity. And this will exaggerate the pressure difference between the portal system and the abdomen. And this has the tendency to encourage fluid to move back from the central circulation into the abdominal cavity at a faster rate. And therefore, the more you remove, the quicker the patient fills up. And these patients are at a greater risk for developing hemodynamic abnormalities known as paracentesis, induced circulatory dysfunction, and clinically manifested as hyponatremia and renal failure. And therefore, albumin has been recommended to be given to patients who receive large volume paracentesis to support the circulation. And this is a meta-analysis done several years ago, confirming the beneficial effects of albumin in terms of averting the development of paracentesis-induced circulatory dysfunction. Now, not every patient wants to be drained on a regular basis, and so for the appropriate patients, a TIPS can be considered. And these are the results of the first 100 patients who received a TIPS at my institution, showing you that after the insertion of a TIPS with return of the splenic blood volume from the splenic blood volume into the central circulation, there is a reduction in the serum creatinine, which continues for at least 6 months, associated with a gradual increase in the urinary sodium excretion, even in the absence of diuretics. I usually tell patients to continue to maintain a sodium restriction until the urinary sodium excretion is above 88 millimoles per day. And as you can see, as you follow these patients, as time goes on, there is an increasing number of patients who completely respond to TIPS insertion with total elimination of the ascites, and the number of patients who still have ascites gradually decreases. However, there is a small percentage of patients, no matter what you do, even with a widely patent TIPS, there is ascites. This is because portal hypertension is only one of the many factors that controls the development of ascites in cirrhosis. This slide shows you that poor liver function can also contribute to non-response. And as you can see in this study, patients with a higher MELD at the time of TIPS insertion had a significantly worse outcome compared to patients with a lower MELD. And for every MELD category, patients with a TIPS always perform better than patients who continue with large volume paracentesis. And therefore, for every patient who presents with refractory ascites, it is necessary to ask the question whether it is appropriate to consider the patient for a TIPS insertion. And the next question is, do we have to wait until the patient has refractory ascites before we consider the patient for a TIPS? And this group of French investigators decided to insert a TIPS for patients who are still using diuretics. The study assessed approximately 60 patients, mostly males, middle-aged with alcoholic cirrhosis. These patients did not have significant liver dysfunction, and they were still on diuretics. And you can see the use of TIPS at a stage before refractory ascites was able to totally control the ascites by the insertion of the tips. In addition, the patients had very good survival after tips insertion. However, this study has yet to be repeated, and therefore currently we cannot recommend the use of a tips at the stage before refractory ascites as a definitive treatment for the ascites. Now, with the increased prevalence of NASH, there is going to be an increased prevalence of diabetes amongst patients with cirrhosis, and therefore the prevalence of CKD in patients with cirrhosis will increase. When these patients develop ascites, there are no clear guidelines as to what to do with these patients, as their response to diuretics will be less than optimal. Repeat large volume paracentesis is acceptable, but try to avoid large volume shifts and give adequate volume replacement in the form of albumin. If these patients become hypotensive, you can use vasoconstrictors such as midodrine, and remember to refer these patients for liver transplant assessment early and treat the underlying cause of CKD if possible. And don't forget to refer patients with ascites for liver transplant assessment, as timely referral for liver transplant assessment is crucial. Patients with good liver function and refractory ascites are usually underserved by the MELD allocation system. If these patients have concomitant hyponatremia, they will go along the waiting list faster than patients who do not have hyponatremia. Even after liver transplant, the ascites can persist for a few months, as it takes that amount of time for the abnormal hemodynamics to reverse. Now let us change gears and look at renal dysfunction in cirrhosis. Renal dysfunction has been estimated to occur in approximately 50% of patients admitted into hospital. And I think everybody knows about hepatorenal syndrome, especially the acute form or type 1 hepatorenal syndrome. It is a condition that is associated with a bad prognosis if left untreated. However, over the years since type 1 hepatorenal syndrome or HRS1 was first defined, the clinicians looking after patients with HRS1 recognize that that is the pre-terminal stage of renal dysfunction. And therefore, over the years, various organizations have tried to redefine renal dysfunction in cirrhosis, hoping to diagnose the condition at a lower level of renal dysfunction and therefore able to start treatment earlier. I have presented to you here the diagnostic criteria of acute kidney injury, which is the nomenclature that's been adopted by the hepatology community to describe renal dysfunction in cirrhosis. So acute kidney injury is defined as an absolute increase in serum creatinine more than or equal to 0.3 milligram per deciliter within 48 hours. However, not all patients will have a serum creatinine level taken 48 hours prior. Usually these patients are being followed on a regular basis, so they should have regular blood work. And if such a patient has a stable serum creatinine in the last 3 months, that could be used as a baseline to calculate a percentage increase in the serum creatinine. And if the patient has experienced a 50% increase of serum creatinine, presumably to have occurred in the last 7 days, then the patient can also be diagnosed to have AKI. Now, the severity of the AKI is defined by stages. Stage 1 is when there is more than 50% increase, but less than doubling of the serum creatinine from baseline. Stage 2 is doubling to trebling from baseline. And stage 3 is more than trebling of the serum creatinine from baseline. And so the type 1 hepatorenal syndrome that we used to know is now defined as AKI-HRS, and it occurs in patients with cirrhosis and ascites who have developed doubling or trebling of the serum creatinine within either 48 hours or within the last 7 days. And such an increase in serum creatinine has to show no improvement after at least 48 hours of diuretic withdrawal and volume expansion with albumin. In addition, the patient cannot have any evidence of structural renal disease or the current or recent use of nephrotoxic drugs or the absence of hypovolemic shock or severe infection requiring the use of vasoactive drugs to maintain arterial pressure. So that is AKI, but more recently, there is another entity that is being recognized in patients with cirrhosis, and that is HRS AKD, or acute kidney disease, which is a milder but acute form of kidney dysfunction than acute kidney injury. It is defined either as a less than 50% increase in the serum creatinine or a reduction in the estimated glomerular filtration rate to less than 60 minutes per mil for less than 3 months. And if the reduction in the estimated glomerular filtration rate has been present for more than 3 months, then the patient is said to have HRS chronic kidney disease or HRS-CKD. Now, I must have confused you with all the terminologies, and so maybe this Venn diagram will be able to explain to you the various phenotypes of liver dysfunction in cirrhosis. So first of all, you have to decide whether the patient has acute kidney injury or chronic kidney disease. And within the category of acute kidney injury, the patient may have structural renal diseases such as acute tubular necrosis, acute glomerulonephritis. And within the category of functional renal diseases, these patients do not have any structural abnormalities in the kidneys. This is usually due to hemodynamic abnormalities. The patient could either have prerenal azotemia, which is responsive to volume replacement, or the patient may have AKI-HRS, which does not respond to volume replacement. The AKI non-HRS will include entities such as AKI, it will be AKD-HRS. And so for patients with chronic kidney disease, this would include conditions such as diabetic nephropathy, hypertensive nephropathy, etc. And patients with CKD may also have acute deterioration of the renal function, and this would be known as AKI on CKD. So I'm going to concentrate the rest of my talk mostly on AKI-HRS. And AKI-HRS frequently is precipitated by an acute event. And this is a study from my institution showing that in patients with HRS, whether they respond to liver transplant or not, usually infection is the most common precipitant of the renal dysfunction. And so when such a patient presents to you, the first thing you need to do is to decide what has caused the AKI. Is that prerenal azotemia due to excess diuresis or severe vomiting or GI blood loss? Or does the patient have structural renal diseases? Or does the patient have acute or chronic renal failure such as dehydration, in a patient with diabetic nephropathy. Or if the patient has had at least doubling of the serum creatinine acutely, then the patient is likely to have AKI-HRS. And so once you've decided the patient has got AKI, you need to remove and treat the underlying precipitating factor. At the same time, you also need to volume expand the patient with albumin at a dose of 1 gram of albumin per kilogram of body weight, with a maximum of 100 grams of albumin per day. If the patient responds by reducing the serum creatinine, well and good, you can monitor the patient closely. If the patient's serum creatinine does not change, then you need to decide exactly what is the phenotype of the AKI and treat accordingly. If the patient's serum creatinine does not respond, or there has been worsening of the serum creatinine, then you need to consider treating the patient with vasoconstrictor and albumin if the patient fulfills the AKI-HRS diagnostic criteria. If the patient responds, very good, you need to monitor these patients very carefully. If the patient does not respond, then you ask the question, is the patient a liver transplant candidate? If so, you need to support the patient with renal replacement therapy. If the patient is not a transplant candidate, then you will need to start discussing with the patient and the family about palliative care. And you must remember, don't sit on these patients, as the delay in initiating treatment can lead to structural damage in the renal tissue, and therefore converting the patient from a potential responder to a non-responder. Now, of all the vasoconstrictors that are available worldwide, Terlipressin is the one that has been used most commonly worldwide, although I know that it is still not yet available in North America. And this is followed by the use of noradrenaline or norepinephrine, followed by midodrine octreotide. A small number of studies have also assessed the effects of dopamine together with furosemide. So far, there are 4 randomized controlled trials assessing the use of terlipressin versus placebo, both with albumin in the treatment of AKI-HRS. And you can see of the 4 studies, at least 3 of them have shown a significant reduction in the serum creatinine following the use of terlipressin compared to placebo. And the response is independent of whether the terlipressin was administered as boluses or as continuous infusion. And in those patients who responded, there was a significant improvement in the survival. And the response to treatment does not necessarily have to be terlipressin and albumin. A small number of patients amongst the 2 earlier terlipressin trials conducted in North America also responded to placebo. And as you can see, patients who responded, whether using terlipressin or placebo, had a significantly better survival compared to patients who did not respond. However, the latest North American terlipressin versus placebo with albumin trial showed a significant increase in the number of patients with respiratory failure in those who received terlipressin, whereas this was not observed in the patients who received placebo. It is felt that the increased incidence of respiratory failure was related to the fact that the vasoconstriction induced by terlipressin in the systemic circulation poses an increase in the afterload resistance, and therefore if these patients also have a degree of cirrhotic cardiomyopathy, this may actually induce the development of cardiac failure, leading to pulmonary edema and therefore the development of respiratory failure. Now, I know that in North America, Terlipressin is not available, and we're still using midodrine octreotide. In this particular study, it shows that midodrine octreotide combination is significantly less effective than Terlipressin in reducing the degree of renal dysfunction, and it's virtually ineffective in inducing reversal of the hepatorenal syndrome. Now, what about norepinephrine? So far, all the trials comparing Terlipressin and norepinephrine are rather small, but by doing a meta-analysis, you can see that norepinephrine is as efficacious as Terlipressin in improving renal function in these patients. However, in the context of acute on chronic liver failure, that is in patients with renal failure and multiple other organ failures, the use of Terlipressin was much more effective in improving the renal function and also in improving the survival in these patients. And however, you have to remember that in patients with significant high-grade acute on chronic liver failure, these are also the patients who develop respiratory failure, and therefore care will have to be exercised in using Terlipressin in patients with multi-organ failure. These patients probably would be better served by being referred for liver transplant. And if we can reduce the serum creatinine and reduce the stage of AKI in these patients with Terlipressin, there is an associated significant improvement in the survival with or without a liver transplant. In fact, it has been shown that you actually do not need a stage reduction in order to derive a survival benefit. This study shows that even if you have a reduction of the serum creatinine by 1 milligram per deciliter, which may not be sufficient for a reduction of one stage of AKI, there is an associated 30% reduction in mortality. So the message is treat early, and even if you have a small reduction in serum creatinine, the patient is likely to benefit. And what about for liver transplant? All of these patients should be referred for liver transplant assessment. The big question is always whether we should do a simultaneous liver and kidney transplant. These are the guidelines provided by the transplant community in patients who have prolonged dialysis time, and in different parts of the world, the guidelines are slightly different. And also in patients who have got underlying chronic kidney disease, these patients should be offered combined liver and kidney transplant. Otherwise, just do a liver transplant alone. Reserve the ability to consider these patients for early kidney transplant if there is no recovery of renal function post-transplant, or if the patient requires dialysis for more than 3 months, or if a simultaneous kidney transplant was not possible at the time of liver transplant. So in summary, renal failure is the most common organ failure in decompensated cirrhotic patients. We need to recognize it early in order to initiate timely treatment. Terlipressin is the most commonly used vasoconstrictor worldwide for AKI and cirrhosis. Small improvement in serum creatinine with treatment is beneficial. Refer for consideration for liver transplant early, as this is associated with improved outcomes. And finally, for the future, we are hoping that we can develop biomarkers that can tell us which patient is susceptible to develop AKI, biomarkers that can tell us the pathogenetic mechanisms, whether it's mostly related to inflammation or hemodynamic abnormalities, and also biomarkers to predict the progression of the AKI and to predict the point of no return so that we can allocate either kidney transplant or renal replacement therapy early. I will stop here and thank you for your attention.